That's a bit better.
Richard, we're live now.
Oh, thank you so much, Karen. That's great. Ladies and gentlemen, members of the panel and public who may have joined us this morning, and I suspect particularly the press, welcome to this morning's adult care panel, adult social care and its relationship with health panel. It's been a big week. We had cabinet on Monday, we had full council yesterday, and we have panel today. So I'm really grateful for the attendance of members, and in our pre-going live, looking very perky indeed, very impressed. We have a range of officers with us this morning who I will introduce as we go along. But just those that I've bumped into this morning already, we've got Chris Badger, the interim director, we've got Helen Manerf, his assistant. Helen, would you like to say hi?
Morning, everybody. Hello.
Morning, Helen. And we've got Stevie Foster, who will be presenting our first agenda item, and we have others who will be coming in later. Now, in terms of, I'm going to do this in a slightly wrong order, but I'm going to do it anyway. I'm still waiting for Simon Bloxham, who is substituting for Fiona Guest. Fiona sends her apologies. She's a pharmacist, and she's at work today, and this additional meeting she wasn't able to change her programme, so that's why she's not with us. And we've got Sarah Bedford, who's substituting for Corrine Harstrick. So Sarah, you're very welcome. Nigel Bell, Julia Gordon has very helpfully told me that that Nigel is sorting out his mother this morning in terms of her accommodation where she's living, so he may not be able to join us this morning either. And I'm not sure if Andrew Stevenson is with us. He might. I think I'm going to accept his apologies as well. So sorry about all that sort of bureaucracy. I now have to get really bureaucratic and read out the chairman's announcement with regard to COVID and the rules that affect us. So due to the coronavirus pandemic, the council will be holding this meeting electronically in accordance with the relevant regulations. Members of the public may also attend this meeting in electronic capacity, and there's a link to the council's website for them to do so. And we are live at the moment. Members of the council are asked to keep their microphones switched off until called to speak. Sorry about that. Members of the council are asked to keep their microphones switched off until called to speak, and to switch their microphones off once they have finished speaking. Cameras may be left on throughout the meeting if members wish. I leave that up to you. For some of you, if we all have our cameras on, it might affect quality. If you experience connection or other technical issues, it may help to switch your camera off. To indicate a wish to speak, members should use the raise hand function. Use of the meeting chat function is exclusively for voting. At the end of the debate on each item business, there will be a vote. Members should vote using the meeting chat function by indicating for, against, or abstain. I will declare the result after each vote. Breaks of at least 15 minutes will be held every 2 hours and will be taken after a speaker in debate has finished speaking. If we are voting, the vote will be concluded before the break is taken. Other breaks will be incorporated as appropriate. As most of us have spent a little while on this meeting already, I suspect in preparation, I will take the first break of 5 minutes, just sometime after 11 o'clock. Members are invited now, just to let me know in the chat function if they have any interest to declare. So whether those are pecuniary or merely an interest they feel that the public may have a view on. And I am seeing nothing in chat, so that's fine. And I've had a message from that Simon Bloxham is now with us, which is excellent. That's good. Thank you. That's good. I just wanted to say, in this final meeting of the year, which is an additional meeting reflecting the amount of business that we've got through this year, and I'm grateful for panel for being here, that actually this comes at a time when, for all of our services, we should just be hugely grateful for all that our staff are doing, from Chris Badger as interim director down through all of our care staff, and then all of those working for in the commissioned providers right across care settings in Hertfordshire. My heart goes out to them, because at the moment it is hard yards. We have more infection than we've had since earlier in the year in peak 1, which means that our hospitals and our care settings, particularly for staffing, are really a little bit stressed at the moment. And it is in that context that we are holding this meeting, and why I'm making these comments. Ron Tyndall yesterday asked me to pass on my thanks to all care staff, and I'm doing this now, and he certainly can do this himself if he wishes to. But absolutely, I accept that all political parties in this at the county council, there is a unanimity at the effort that staff have gone to in how they carry out their jobs, and we are as one in thanking you for what you do. So I'm just going to pause there for a moment. Did anybody at that moment want to come in? No.
Can I just add, Richard, that I think the one thing I think that stands out for us and the way in which our staff have performed is the fact that we have not had to use any of the easements on social care that the government put into place at the beginning of this disastrous thing, and that we have managed to soldier on throughout the year, giving as much the best service we could. And I think that every member of the staff, right from top to bottom, has to be proud to actually have achieved that.
Thank you, Ron. That's really appreciated. Dreda?
Thank you, Chair. Just to echo your comments and those of Ron, and I think our staff have done an absolutely remarkable job across the board, adapting all the while into an ever-changing, unpredictable set of circumstances. So well done, and I'm hoping that come next week that some of them anyway will be able to enjoy a well-deserved rest.
Yeah. Thank you both. That's lovely. Great. Right, I now take us to, I think what I will do now is ask you all, that's members of the panel, to introduce yourselves so that those who are watching this know who's behind the name and can just see who you are. So if I could, Sarah, would you like to just introduce yourself, perhaps say where you're from, what you do?
Councillor Sarah Bedford from Abbots Langley, also a Three Rivers councillor. Thanks,
Sarah. Nigel Bell has sent his apologies. Simon, are you there? Simon Bloxham? No, we'll catch up with Simon later. Dreda, we've seen you. You've had your chance. Right. Dave Hewitt. I know you're. No.
Sorry, just waiting for the mic to come on. It wouldn't switch on.
No worries.
Yeah, I'm Dave Hewitt. I represent Cheshunt Central in Broxbourne. Thank you.
Thank you, Dave. I'm going to come back to Dreda. Dreda, you haven't had a chance to introduce yourself properly. Please do so.
Oh, thank you. That is very kind. Dreda Gordon, Labour spokesperson on the Adult Care Panel, councillor for the London Coney.
There we are. Thank you, Dreda. Fiona Hill, who.
Thank you, Chairman. Deputy Executive Member for Adult Care and Health and Conservative Member for Royston East and Ermine.
Thanks, Fiona. Tina.
Good morning. I'm Tina Howard, representative for Hemel Hempstead South East. Thank you.
Thank you, Tina. Jonathan.
Yes, I'm Jonathan Kay. I'm a Conservative councillor for Ware South and chairman of East Herts Council as well.
There we are. Thank you, Jonathan. Nigel Quentin.
Morning, everybody. Nigel Quinton, I represent Hansard and Pear Tree in the centre of Welwyn Garden City for the Lib Dems.
Okay. Then there's me. So I'm the executive member for Adult Social Care and Health. I represent the ward of Kings Langley, and I'm also the chairman of the Health and Wellbeing Board. Thank you. Andrew Stevenson has sent his apologies. Ron.
Thank you, Chair, and hello, everybody. Ron Tyndall, County Councillor for Hemel Hempstead St Paul's and Liberal Democrat portfolio holder for adult care.
There we are. That's good. Thank you, Ron. And the husband of our current chairman, William.
William Wyatt Lowe. I represent Hemel Hempstead Town, and I'm also Hertfordshire's appointed governor to the Royal Free NHS Trust.
Thank you. For those who are wondering, that isn't my husband. That's Colette Wyatt Lowe, the chairman of the county council. That's fine. Thank you so much. And we're still waiting, I think, for Simon to join us, but that's fine. So let's just move to the minutes. So first, can I just check that those are an accurate record of our meeting from the 2nd of November?
Okay.
Okay, so actually what we have to, I'm being reminded that we need to formally agree these. Would you like to do that, please? In the chat function. And then at some point I must go up to County Hall and sign all these minutes, because there are now about 9 months worth that have stacked up across a number of committees. So this being one of them. Okay. Just while we're waiting for anybody else to, I think that's agreed. 1 or 2 more still coming through. That's fine. Are there any matters arising that you don't feel have been dealt with in the intervening period, or that are and or of course are not on the agenda today? But any matters arising, now would be as good a time to. Ron's hand is up. So Ron, can I just check? Is that you want to come in now?
Yes, please. If I may, it's not a question on the minutes. It's not a correction or anything like that. What it is an update, really. 6.2 refers to support to care providers. And we put in place something that makes sure that none of our care providers fall over. And I just wondered if, as there's nothing apparently on the agenda that refers to this, given the fluid situation, whether we could have an update from the interim director, because I do believe things are tight in some areas, particularly with the number of bed vacancies in various care homes. This, of course, brings their financial viability into question.
Thank you, Ron. As you know, that the Infection Control Fund, the government has given us 2 tranches of that, which have been invested into 80% of which has gone directly into care providers, and the process and the amounts of money that have gone in and how the monies are claimed have come to this panel on both occasions, and have then been through Cabinet. In terms of, and within that, of course, is the sustainability element, where we have discretion on which care providers that we support, particularly with their bed allocation. I don't know if, Chris, do you want to add anything further?
Just to say, clearly we've now got a position we've written to providers further to Cabinet decisions to be clear that our funding continues until the end of the financial year. We thought it was important to provide as much certainty to providers as possible. So a couple of elements in terms of the support. Number one, we are seeing a pretty robust supply of PPE through the national portal, where we had been providing support before that was established. The feedback on that is on the whole positive, so that's been very helpful for providers. Second one is around that issue around sort of sustainability, Ron, and under occupancy. We're monitoring that very closely. We look at that all the time in terms of bed occupancy, but also financial health of different providers. We're clearly supporting a number of providers in that, but we haven't seen that increase markedly over the last few months. Clearly, in the new year, it's going to be really important that we get the support around vaccinations into the care homes, which is a priority in the government's list. That will clearly help with care homes in terms of how they can run, and also, clearly, I think in the next year, a very different picture around demand and care homes to do that. But we're keeping a very close eye on it and monitoring the occupancy levels and dealing with individual providers where issues arise.
If I may, Chris, are we ensuring that we're not just dispensing money to which are commercial operations, but we are and other organisations, but we are actually getting a quid for our quo, as it were, in terms of nominations to their bed spaces?
Yeah, it's an important point, Ron, and it was a point we made very clear in the policy that we agreed for how we would apply support where we have some discretion, and it was absolutely along those lines, Ron, that it would be clear that for a variety of reasons around state aid and so forth, we can't just provide money. We need to be clear that that then supports the wider health and social care system in Hertfordshire residents with capacity and access to beds at rates that are viable for the taxpayer, essentially through our funds. So absolutely, that each of those discussions involves an agreement being reached on exactly that, Ron.
Thank you very much. Thank you, Chair.
Just to reiterate, and bring in Nigel in a moment, but just to reiterate, it was setting out the criteria and the protocol about how care providers would be supported and how they would claim from the county council for the monies that government was sending through to us. That has meant that we have had a financial regime, which I suspect means that the council is on top of its finances, but also the care providers have had certainty about financing from the start of this pandemic. And that may be why we have had fewer failures in the market than we might have expected. And also, I mean, hats off to the government. There was concern that the PPE portal may fall over, and it hasn't. It's worked very well, and I think we're grateful for that. Nigel.
Thank you, Chair. Yeah, I just had a question on 10.4 of the minutes. We discussed the flu vaccine last time, and there was concern about where it was at. Helen was going to talk to officers. I wonder if she could just give us an update. I believe the situation is much improved, but I'd like to hear from her.
I thought, Nigel, we almost got an update during. There's so many meetings. I do apologise. I thought it was yesterday, but the last I heard, it was 87% for care home residents, which is really good, and about 35% for staff. But let's see if Helen's got any further. Helen or Chris have any further update. Thanks, Nigel.
Chairman, I don't have any further update on top of what you just said.
Okay, there we are. So just absolutely right to show concern there, Nigel, and it a big effort to get staff jabbed and protected against flu, and in fact that's quite a significant increase in care staff as well. So that's a big improvement in that area. Thank you. Good. I think we just checking. Yeah, we're in good shape. Moving to, so the minutes are accepted. Thank you very much, and thank you for that. The matters arising there. Public petitions, there are none. And so we'll now move to agenda item 3, which is the annual report for 2019-20, although it's a slightly longer period, from Hearts at Home Limited. And we have Director Stephen Lee Foster to help present, but we also have with us, I'm fairly certain, Managing Director Melanie Yeoman, who is on day-to-day running of this service. And if I could ask Steve to perhaps, before introducing the report itself, perhaps introduce the directors or introduce the setup of the company so that we understand its status and what it's doing. Thank you, Steve.
Thank you, Chairman. Just very briefly then, it's the second birthday of the company, or was last week. Panel previously received a report
last November. So this is the second report from the company that's come before the panel. Still a relatively small board. There's myself, Operations Director in Adult Care Services, and appointed chairman of the company's board. I represent the County Council formally. However, we also have Stephen Pillsworth, who took over the reins from Taryn Pearson Rose earlier this year. He's the formal shareholder representative. Panel members might recall that the company is wholly owned by the County Council. There's no other shareholders. So Stephen's role is really to keep a formal eye on the company's affairs and, if necessary, give formal direction to the board. Then there's Beverly Flowers. Some of the panel members may know Beverly, Strategic Director at the CCG, North East Herts. And finally, Gillian Quinton, who's the Director of Adult Social Care Services, Housing and Health at Buckinghamshire County Council. So quite a small board, but relatively strong. Going forward, the board is going to do some due diligence on whether we think we need to expand that as the company grows. So that's a little bit about the company.
Thanks for doing that, Steve, because I think that the strength in that sort of non-exec team is really important and very reassuring to me, and I suspect to panel that it's really well founded and well set up. But thank you.
I'm just going to speak for a very brief time just to highlight some of the main points, and then I'm going to hand over to Mel. Mel Yeoman's our Managing Director, has been with the company, like myself, almost from the outset, and she can take you through some of the detailed operational challenges and successes that we've faced over the past year or so. So just very briefly, the company's turnover has increased quite rapidly. All our income, or the lion's share, comes from the County Council. We're not treated any differently in that respect to any other provider. We have the same contracts in place, the same monitoring arrangements with the commissioning team. We've, like all providers, have been dealing with the impact of the pandemic, but we have also, the report points out, taken 3 transfers of services since the beginning of the year. 2 of those are extra care, flexi care services. So we now manage 9 of those across the county, the majority in the north, but we've got 9 flexi care services. So that's a significant part of the overall provision in the county. We have also expanded our domiciliary care service to cover rural areas in North Herts as well as Letchworth and also Royston. And finally, at the end of September, we took on the specialist care at home contract for North Herts, and members might recall that that's sometimes badged as reablement. It's primarily the intensive support when people leave hospital. So it's been a very busy year for Mel and the team. Paragraph 2.2 in the Cabinet Panel report sets out really the nub of what the company is for. We were set up not really to make profit, although legally and also from a general fiduciary duty point of view, we try to trade so that we make a small surplus each year. But primarily we're there to offer, I guess, a good word is a counterweight. So one is to give Chris and Helen and colleagues real insight into how operationally policies are panning out on the ground. So we've implemented the uplift that members agreed for frontline care workers, and we've seen an increase in recruitment activity. You know, members will know it's been incredibly difficult for many years. A lot of providers fishing in the same pond, a very buoyant employment market, and all providers, including the council's own services, have found it really difficult to attract good calibre staff. Well, we are seeing a change to that, and Mel will touch on that, and that's been really helped by members taking that decision to invest in frontline staff. So that's I don't want to overplay it at the moment because it's a very difficult employment market with everything members will be aware of in the press, but it's absolutely made a big impact on the ground, not just in terms of recruitment, but also being able to support staff to have a reasonable standard of living and retention as well. And then finally, the report includes a couple of sections on COVID, PPE, and the support we've received, a little bit of support from the Infection Control Fund for our operation, significant to cover our costs with PPE, and also the companies had to back cover some staffing, for example, when an employee is self-isolating. It's been a very busy year. I'm not going to say anything else. I'm just going to hand over, if it's all right, Chairman, to Mel, just to briefly update the panel on the operational side.
Stephen, that's a really helpful intro. Thank you so much. And Mel, are you there? Are you able to join us?
I am. Hi.
Hi there.
Yeah, so sorry.
Morning, Mel. Lovely to see you.
Morning.
Can I just say, panel won't appreciate this, but I have met Mel a couple of times now, actually in the flesh, out and about, in settings, and I just miss that over the last 9 months, just getting out and about to understand how the business is doing. But Mel, it's great to see you on screen this morning, and thanks for being with us and to provide some flesh on the bones that Steve has started off with. Thank you.
Probably our recruitment is our biggest driver at the moment. With taking on the new services, obviously we need to ensure that support is in place for vulnerable people, and we are recruiting between sort of 2 to 5 people per week to help and support with the council with taking on new packages, sustaining our packages of care that are already in the community. We've obviously taken on the special care at home aspect, and that's been a really good fluid movement through that service, good outcomes for service users in terms of people not even needing a service or needing a small service after their stay in hospital while they've lost their confidence. We're regaining those confidence, so really good outcomes are starting to come through on that. Things been a big aspect and challenge for us. Obviously the training's stopped, especially for moving and handling, medication, care certificates. So those are our mandatory kind of fields that we need to ensure that our staff are equipped and enabled to deliver that care. And we've developed new processes through that. We've used in-house company resources, train the trainer. We've used teams to support us with that. We've had COVID spaces for new staff to come in and support on the induction programme. So we've done really well to keep that training up and running. We've now got some equipment that's coming from HES that we're using in one of our rooms to help and support with moving and handling, and that's been brilliant, and we've been starting that from last week. And we started the care certificate through the HCPA. So that's the week-long care certificate, and that's being done by on Teams. We purchased some laptops to help and support new carers to use those laptops to ensure that we could get those people on those programs. So that's been a really good aspect of coming out of sort of like the midst of the pandemic in the beginning, where we've continued to support staff and new staff coming through with that training. The investment in new staff has been great because we've built up our back office staff, and that's helped us and supported us along with our rostering. So we've got a better system of rostering our service users, making sure there's bubbles in place to support our service users, so we don't have any more than a certain amount of care workers going into a service user. All our staff have been trained in donning and donning off. We utilise the CCG training for that. We have regular training of that every 4 weeks to ensure that staff know the importance of donning and donning off and use of PPE. We use the government call portal to ensure that we've got enough stocks of our PPE supplies, and we've used some of the COVID monies to help us with delivery services to each service so that PPE goes directly to those services. So yes, I think all in all we're growing the service. That's always a challenge, but we're recruiting in line with that as well. So that seems to be working well. We've got a steady pace. But obviously the demands are high from our hospital kind of discharges, from our locality teams, but we're making sure that we work really well with those teams to try and support them. But equally, I have to keep the staff safe, and I have to ensure that we can deliver that safely to those service users. So just giving you a slight overview. Hopefully that's okay.
Richard, you're on mute.
You're muted, Richard.
There we are. Talking to myself again. Mel, thank you for that. Thank you for that. That's great. You know the answer to this. I know the answer to this, but I'm going to ask you anyway. CQC came knocking, and do they have anything to say?
We've had some communication from CQC, very little really. We've kept up in line with all.
For goodness sake. They came and they inspected you and found you were good in your first year of operation, which I understand is not a miracle, but is a real pat on the back for the organisation that in its first year of operation, it's already achieved the standard of good. That's all I was hinting at. Cool. I tell you what, Mel, I'll let members ask questions. So I'm going to start with Ron. Then I've got Jonathan and William, and probably others as well. Thank you.
Thank you, Chair. I've got a couple. First of all, on paragraph 4.3 of the paper, and then also page 6 of the company report, I'm concerned about it seems as if you have had, over a period of time, 3 or 4 different company staff transfers, and then you are recruiting staff. And I just wonder whether or not you've managed to reconcile it so that all staff are now on the same terms and conditions working together, or whether or not there is still an imbalance in the different terms and conditions, because if you've got 2 people working alongside each other, that can cause a friction sometimes. That's one for me. Then I've got another one for somebody else.
Okay. Yeah, that has been a challenge to bring people in over the company under 2 people. We've achieved 87% of staff now working within the Hearts at Home terms and conditions. So that's been a massive increase from last year, where we only had about 26%. So now we're achieving that. People are looking at our terms and conditions as favourable. It hasn't caused a problem in between, colleagues working together. That hasn't caused a problem. Yeah.
And you also, in the report, as I say, on page 6, there's a comment which I wondered if you could comment on. If you look on page 6, Hearts at Home Limited as an employer, and you go down to the 6th bullet point, it mentions the demands of the local market, but will be developed carefully in order not to distort the market. I wonder if you could expand that, please.
Would you? Yeah, I think I'm going to ask Steve to answer that, because that's not really a day-to-day operational question. So, Steve, could you come in?
Yes. Thank you, Chairman. Ron, the undertaking that we have is the same with all the other lead providers in the sense of home care. So we we notify another provider if a member of staff applies for a role with that potential employee's consent. And that's a protocol that the county council and providers have agreed. So that's a practical example of where we form part, as it were, of that provider. I don't want to use the best way. It's like a collective response. So that's where we're all trying to put the interests of the care delivery above, in particular, sort of staffing challenges.
Would you say that if you look at 2 bullet points above, adherence to the Hertfordshire care standards, that by the council fostering the care association providers to come together and work together and in terms of recruitment and everything else, it means it avoids friction and can actually enable the market to develop in the best way possible.
Thank you, Steve. Thank you, Ron. I'm just gonna bring in Chris as well. And one of the things I'm more than aware of here is these are private companies that we are competing with, and that point has been well made, and we're really cognizant of that fact. So, Chris, just bringing you in, because I think that's the point Ron is hinting at here.
As director, I've got a responsibility on behalf of the council for the sound management of the care market within Hertfordshire. So clearly we need to be aware of anything that we do through the company we own has to be in the benefit of that wider market. So one of these things is to give us some protection if were there to be another market failure, Allied, and this gives us that opportunity and is being used to do that. But also, what we can't then do is look to set terms and conditions significantly above the market, the rest of the care market, so that it would destabilise the market, namely by significant numbers of people joining Hearts at Home from other care providers, which in a sense, if to use the term, robs Peter to pay Paul, and actually makes those organisations more sort of unsustainable, where we'll have to be in a position to support if that were to become a market failure. So it means that we have to be really cognizant with the directions that Steve then gives the company about responsibility in terms of how it operates, so that it's really aware of the impact it may have on other providers. The flip side of that is we would expect there to be a set of standards as outlined in the Hearts Care standards and what we consider fair levels of pay that we would expect others to adhere to, because if they don't, they'll people will vote with their feet. So it's a fine line between setting a good example around terms and conditions, but not going so far as to distort other providers and affect the market volatility.
Is it worth just a quick word on the new contracts around specialist care at home, and just how, again, that is being really reflective of the market and giving providers every opportunity to have a chunk of the Hertfordshire market.
Yeah, Joe, do you want me to? I'll answer that once. It's a wider market point. Yeah, so those contracts are designed to ensure that those providers build up a really significant proportion of the market share, because they've got an expertise in reablement services and securing people's independence. So we contract that with a number of mechanisms that allows those providers to be as flexible as possible in the deployment of staff. So moving away from, for example, minute by minute billing to banded rates, which allows there to be much more flexibility to really make it economically viable for carers to spend more time with individuals, so that providers and therefore the care staff aren't penalised financially for spending more time with people, because actually we sort the contracting and the billing out in a way that gives much more flexibility. And you'll see that in, for example, a very, very low rate now of 15-minute visits across all home care services, and an ability for the rosters, etc., to be developed in a way that supports service users better. Cost us a bit more because we're having to be a bit more permissive in terms of the finance model, but we think that's a better investment for outcomes for people.
Okay, thank you. Thank you, Ron, and thank you for Mel. Stay there, Jonathan.
Thanks very much, Chairman. It's very much on the theme of what Chris was actually just talking about. If you're recruiting, Melanie, 2 to 5 people a week, is that easy, or is that actually quite difficult? But also, is there a theme where you're getting a lot of people applying from company X because they say company X is, dreadful or trying to get out or whatever? But I mean, this presumably helps you, gain a picture of the general care worker brigade, as it were, so you know what's happening generally in the area.
Thanks, Jonathan. So, Mel.
No, I've had mainly new people coming through wanting to be in care. There's 1 or 2 people that have come through from other care agencies, some that are private out there, but not huge amounts, and there hasn't been those kind of discussions really. I think people are staying where they are, seems to be, in this market.
Because of the current situation.
Yeah.
Yeah. Okay, thanks very much.
Thank you, Jonathan. And Drida. And then William.
Yeah, thank you, Chair. And thanks to Stephen and Melanie for their presentations. My question is in relation to residential and nursing care on page 14. And adult care services have approached Hearts at Home with a view to incorporating nursing care into your agreement. And I just wondered, are we at any stage in discussions or planned discussions with NHS providers in order to make that a reality?
Yeah, do you want me to come in there, Richard?
Yeah, go on, Chris.
Yeah, I think it's a really good point, Drida. So we are considering.
Very pertinent.
Yeah, we are considering this. Clearly, we as panel will know, we've got a capital programme around nursing home provision in particular, which is an area where we in certain parts of the county we haven't got the provision that we need, and we need to stimulate the market there and secure more provision. We are actively looking at what models of delivery we would have in those care homes. So with the first one in Wormley, we've got a delivery model with a partner care home company. Others, we are actively looking at whether a model with Hearts at Home or a different, more direct delivery model would be beneficial. And absolutely, we have begun conversations with NHS colleagues, particularly around that nursing element, to see if we can link up the nursing element in a care home with the wider community nursing provision in that area. I think could have some real benefits, Drida. So that's an exciting model that we want to look at, and spoken to both community trusts, so also interested in working with us on that. And I think there's probably some learning from the last year about the support that care homes require, which I think is now much more on a lot more people's radar and agenda. And I think joining that up with NHS colleagues is something that the whole of our health and social care system is committed to. And I think we could look to really take that forward in quite an exciting way. Lots of different models, which we'll have to appraise the options around how you would do it. But I think there's stuff that we can really take from COVID that would make that really quite exciting in the future.
Thank you.
And I think I mentioned at full council yesterday, quite an exciting sort of capital programme of building new nursing homes, and your question very much sort of ties into that as well. So we'll certainly be appraising panel of how that workforce and an agency join up is progressing. Yeah, great question there, Drida. Thank you, William.
I'd like to thank you for including values, vision and principles in your report. Much appreciated and largely admirable. My question now is about ambition. How long do you expect it to take for you to double your 219 staff? And are there any geographic areas at which you are looking? For example, Buckinghamshire, because you've got somebody on the board, or perhaps further south, which would be of interest to me in Hertsmere.
Steve, can you come in on that one?
Yeah. Yes, thank you, Chairman. We're zoned in the simplest sense, in that, like other providers, the county council's tendering services based on geographic parcels. So the company wouldn't do anything unilaterally to depart from that. So we're entirely focused on Hertfordshire and will continue to be so. We're not in the pond fishing for private self-funders either, simply for the reason that given the challenges Mel has outlined in the past year, that we don't want to decline a request to take on somebody's support needs because we're investing energy in, the home assistance, ironing, shopping, that kind of more private mixed with care sort of activity. We're entirely focused on supporting Chris and Helen in terms of the council's strategic sort of focus. So the short answer is no mission creep. And it can't be allowed formally anyway, in the sense that I report to Chris and Stephen Pillsworth is there to put a check if we did one. But it's also very mature for us to be able to have that conversation, because it allows us to explore with officers, both in the company and the county council, some of the pressures of running the business. But we are not intending and don't foresee any geographical creep or indeed focus moving away from what we're currently doing, save what's in the report about scoping in the future around potential residential or nursing. But that's literally just scoping at the moment.
Thank you, William. You never ask anything other than a challenging question. That's brilliant.
I didn't get an answer to how long to double either.
Well, I don't. I think if I could paraphrase, no. There isn't an ambition per se to double the size of the organisation. It is to provide excellent service for what it already is running, and to be a fallback for when providers get in trouble, and we can. And that's so it's fulfilling two roles really. And I think Mel might want to come in a little bit on the culture, but I mean one of the areas where is a both a challenge and now a strength is around incorporating employees from organisations and then bringing them together to work together. And I suspect if the business was expanded too rapidly, that would become very, very, very challenging indeed, especially when it's needs to be that backstop and ready to accept a market failure and to step in that way. But so that's my take on it, William. Mel, did you want to add anything? I wonder if
no, I think it's just stabilising. We've stabilised, those 2P transfers, created a really good culture of what is Hearts at Home. So that's and those values and behaviours have gone down through through the company, and they're being instilled in all employees. So now to have a breathing space and look back on that is just it's going to be a fantastic way of looking back and how we've developed, and all of us have developed, because every single one of the companies that we took on from different ways of working, different standards and quality. So it's bringing the quality and standards up to what we would like to deliver. So yeah.
Thank you, Mel. And Ron, you wanted to come back in again, and then I'll bring in Dave.
Stephen just said about not fishing for self-funders. In 5.2 on page 3, there is a comment and a small amount of income from private clients. If we're not fishing for self-funders, I wonder where that comes from.
Steve.
Yeah, thank you, Ron. We inherited those is the short answer. So there's continuity of care on the point the services were transferred. So I mean, we have had a bit of a discussion with Chris and colleagues about the future business plan of the company, because we do need a refresh and a bit of a pause and recharge after an incredibly demanding year. So that would also address the point that William made about whether we want as a board or with the county council to set an ambition both on private funders but also growth through, you know, in business language it would be called organic growth, wouldn't it, through acquiring. It's quite slow, but we just need to know how where to position the gas, to use the driving analogy or American term, so that we're not going too fast, but equally Chris is assured that we've got sufficient presence in the care market locally, that we can do the things that we were set up to do. So
Thank you, Stephen. I must admit, my own view is that the company should very much remain with its primarily objective, which is as a stopgap and a way in which we can seamlessly take over other people's care if a private provider falls over, particularly with the government still refusing to give us a sustainable care future and a lack of a future for the care industry. I dread to think what's going to happen over the next year or so if somebody doesn't get their finger out at the Department of Health and Care. Thanks very much.
Thank you, Ron. Good political point there. Dave Hewitt.
Thank you, Chairman, and thank you for your report. Very interesting. Question really in two parts. Given that there are so many people being made redundant from all sorts of sectors, primarily hospitality sector, I suspect that recruitment for you had been increased, and given that eventually and hopefully this and other sectors will get moving, are we confident that new recruits that we have received can be replaced at such time as they return to their other occupations and probably more lucrative occupations? And to what extent, and this is the second part of my question, are you using agency staff to fill any gaps? Thank you.
There we are. So new recruits and agency staff. Mel.
Yep. So the recruits coming through, we're very stringent with our selection process. So actually, some people, they've got to have some kind of interaction that they've had previously with somebody, to could be mum, dad, and also because we have to invest quite a bit in that person with training, and that there's a lot of investment. So we are very selective with our candidates that come through. And to date, since March, we've had, obviously, there's been redundancies happening since April, and we haven't had anyone resign from these jobs yet. We've had people from airlines, and the feedback that we've had from our staff surveys has been that people actually are absolutely enjoying having a new start in a new career. That's really
uplifting, Mel. So we've got folks who've already had careers and then coming into care. That's really quite heartwarming. Thank you. And then on Dave's point about agency, do we require agency staffing?
We do, because we use three agencies that we've used since the company has started. And we've got a select staffing group from those three agencies that we continuously use those people. Some people have come across to us as permanent members of staff, but we use those staff members to give continuity, because our service users do know those people. But there's always this element in between taking our new packages to recruitment, and there's a crossover aspects.
Okay, thank you, Mel. I have no one else who's indicated they wish to speak. Stephen, did you want to any final comments from you? Thank you, Dave.
Well, only so two things, Chairman. One was that there was an informal meeting of Cabinet looking at trading companies in the autumn, and the company participated in that. And I think going forward, there was reassurance around the governance framework. The technical term is scheme of delegation. So that's all in place. So members can take some credit for the robustness of those arrangements. The company's still relatively small, but that said, it's not a small business. So going forward, we do want to have a look at the business plan and set that out. And that's probably best done over the sort of spring when we know where we are vis-a-vis the pandemic. But equally, it will help some of the questions from the panel this morning. It will help articulate the position going forward in terms of what the County Council wants to set out, as it were, as that future road. So that's all I would add, Mr. Chairman. Thank you.
Thank you. I think that's Mel. Thank you, and Steve and Chris as well. I think you've really given panel a flavour of that balance between scale, ambition, quality, consistency, and also that helping us to realise that this is both a backstop, but it also has to be challenging in a sense, keeping standards where this is again a very high profile in terms of recognisable standards. So I'm really grateful for what you've added to the report. And the report itself was a good read. So thank you very much. We will see you next year in the formal sense, I hope, and other members may wish to visit with you, Mel and Steve. And on the basis that you're actually directly above the County Council building, above the registry office at County Hall, there is no reason why people can't pop in and say hello. So I look forward to seeing you in care settings. And to see the business in the flesh, so to speak. But until next year, thank you so much for this report. Good luck, and good at the moment. CQC, there is an outstanding to aim for, Mel. So
we are aiming for that. So we're looking at the lessons and how we learn and how we impact on people and everything that we do. So that's the next part that we're looking at.
No pressure there, but I'm hugely respectful of your achieving good in the first year. That was really very, very impressive indeed. Thank you. Good. Panel, would you do me the honours of noting this report, whether you agree with its content? Thank you very much. There we are. We have a panel. Thank you very much. There may be others to come through, but the sentiment is there, and the majority is that report is agreed. Thank you again for our officer's contribution on that. That's lovely. We'll move on to agenda item 4, which is the performance monitor for Q2, and it's also the local account, which is effectively self-evaluation and reflection back over the last couple of years attached to that as well. So I've got Alex Ogle to present the report, but just before he does, I would also like to, Alex, make yourself known, come wave at us, but I would also like to thank the contributors to the performance report, of which there are many, but these 4 were specifically mentioned: Helen Miriams, Caroline Floyd, Yazid, Lala Holamed, Ian Baines, and Zinnia Demetrio. I can't read my own writing, I do apologise. I just wanted to say So what I wanted to do was say thank you to the performance team, who do an inordinately large amount of work to track what is a big department, and that report that comes before us is the work of many people. Alex, give us the highlights and the lowlights of Q2, and we've got in there, of course, we've got the care standards, and there's some interesting KPIs in that as well.
Yeah, so I'm going to go through. I'll go through the highlights of the performance report. I think Colby is here to follow on with the care standards, and I know in the
lovely
this performance report there's a bit about our kind of monitoring, which I won't go through in much detail because it is sort of including what Colby will go through. The other thing that's just for noting at the moment, unless anybody particularly wants to go through it in detail, is the ACS local account, which is Appendix 4 of this report as well, and that's just for noting at the moment. So I think when we came in Q1, we were in a bit of a different situation under COVID, because obviously activity performance was very much waiting to kind of see the effects of COVID generally, and we're still sort of in that time period for the Q2 performance. Appendix 3 of this report kind of shows some of the activity that we've had. So a lot of our activity is kind of returning to normal generally, kind of pre-COVID levels. So contacts coming through our front door are kind of getting back to where they were previously. Referrals, cases progressing to a kind of what we call referrals are getting back to normal. And there's a lot of work going on around kind of discharge to assess pathways, which are these pathways out of hospital. And those are having a kind of effect, which we're trying to get used to a little bit in regards to performance and how cases are handled post-hospital discharge. A kind of key note is things around residential and nursing placements, which we'll go through briefly, is still seeing a bit of a catch up. So we're seeing much lower volumes of that for adults. But the expectation is that those will start to get a bit closer, but we're probably likely to see a much, well, from the perspective of performance, a better performance, but it's much lower adults going into residential and nursing. So the first one we regularly look at is the employment figures. These dropped a little bit into Q2. So they went from 6.3 to 6.2%. Nationally at the moment, and I reference it's not necessarily in here yet, although we've just had the benchmarking nationally. We generally sit quite well for our performance, even at 6.2%. Essex previously were very high, and I think we chatted last time here that has changed position a little bit, so they're a bit lower than 16% for last year. But generally, our performance nationally on that is quite good actually, and we've done a bit of a breakdown there of across our adult disability service and our transition service of 0 to 25, so you can see the kind of breakdown of where that performance sits. So we tend to do better in those kind of 26 to 64 adults, whereas the 0 to 25 service is a bit lower, and that's generally, and I know I've said before, that's generally due to long-term education, that they might still be in at that point and therefore not employment. So that performance drops a little bit when you look at those 18 to 25 adults. But generally a slight drop, and in Q3 that's gone up a little bit so far, and I know next time we see the report you'll see that that's increased a little bit since last time.
And probably on that point, we're going to have to work incredibly hard in the next year or so as the employment market is challenged. And I think we'll just leave that hanging in the air. Thank you.
Okay. The next one we were looking at was the 91-day indicator, which has improved. Interestingly, it dropped a little bit in Q1 compared to the end of last year. Improved in Q1 compared to the end of last year, and it's improved again in Q2. So this is, for those that don't know the background, this is looking at a 3-month period of discharges for adults that went into our enabling style care services. And it kind of looks at those that are still at home on what they call the 91st day. So that basically means they're not in hospital, they've not passed away, or they're not in a residential or nursing setting. And we tend to perform quite well nationally on this. So we're 85.2% for Q2. And the breakdowns I've given you there is just a bit of a view across the age bandings and genders to see how that performance relates across those kind of different demographics. So we tend to do quite well for female adults over 85. You can see their performance is 91.2%. The lowest performing generally is male adults aged 65 to 74. But performance on that is improving at the moment. And it's a particularly interesting one to keep an eye on at the moment, because like we say, we've got these discharge to assess pathways that have been slightly changed post-COVID, but you've still got people coming through those pathways and going through enabling style care as one of those routes. It'll be interesting to see how this changes over the rest of the year. I'll just keep going, Richard, unless there's any.
Please do, Alex. Please do, yeah.
The next one we looked at normally is the safeguarding satisfaction. So these are adults who've been through a safeguarding inquiry, who have been asked whether they have any outcomes they'd like to achieve as part of that inquiry, and then the proportion of those that are either fully or partially achieved. And we tend to do quite well on this as well. 96%, slightly down from where we were in Q1. Nationally, again, we tend to do quite well, but at the moment, only about 3/4 of authorities are actually reporting this as part of their statutory information. So the benchmarking isn't complete necessarily. And we've got a bit of a breakdown there again between the female and male adults. So male adults tend to report better as a cohort for this. And then we'd also look at our adults by support needs. So this is, you can see their sensory support, much lower numbers of adults in that number. Hence why it's got a good performance. But the lowest performing there as a proportion is adults requiring support with memory and cognition, which is about 86%. So that's adults with dementia that report through in that format.
Those are still high values. Yeah. Thank you, Alex. Yeah, really good.
And then we do the usual, which is direct payments, which are actually seeing a good increase. So what I would say is these are adults receiving community-based services, not residential or nursing care, that have chosen to take their personal budget provided by the council in the form of a direct payment. And generally, we had our best performance at the end of last year, which was 28.6%. Dropped a little bit in Q1, but that is improving again. And I would say that 28% is a figure that we've not been above for a few years. Now, the proportion of adults in community receiving community services under COVID has dropped. And as a proportion of that, the direct payments has increased. And you can see there's a bit of a breakdown by our service areas, east and west. So you've got your 0 to 25 service, which tend to do really quite well with direct payments. So 65.2% of their adults choose to take a direct payment. Our adult disability services also do quite well. And you can see in Q2, both of those areas improved. And our older people services in particular, which nationally is a picture that older people 65 and over tend to have lower proportions receiving direct payments. But in particular, those two areas have performed better than they have for the last 2 years in Q2. So you can see 15.6 for East and North and 17.6 for Hearts Valley. So some good results there as well for direct payments.
Thank you.
Okay, and then carers, again, this has been an improvement. So this is above target at the moment. So that's gone to 76.5% of our carers receiving a direct payment. Again, a bit of a breakdown by our service areas, and you can see improvements across the board there. 0 to 25, generally every service they provide is a direct payment for carers, whereas the other areas might provide other indirect services such as short breaks or carers breaks in general, which is why there's not a full 100% cohort in there. But generally performance on that is improved significantly, and we did a big piece of work in the last few months about contacting carers and making sure they have the support they needed, and that has increased some of the performance there in regards to more carers uptaking direct payments from that perspective as well. Okay. Safeguarding concerns, a slightly interesting one because concerns have been down. Just before COVID sort of officially hit in March, we had a reduction. We started to see a reduction already in concerns coming through the front door, and that was because of two things. One was a change, an improvement in the way medication errors were recorded on the system. And the second being that we introduced the safeguarding portal for professionals, where professionals go in and fill a form in, and that's doing some kind of better triaging before it comes to our safeguarding team. So we saw numbers start to decrease already under COVID. COVID then saw a reduction in Q1 from the end of the year. And we're probably now in Q2, Q3, these are probably the numbers that are sort of settling down post all of those things. We've kind of got back to almost where we were pre-COVID, but with those changes with the portal and with the changes with the medication areas, this is probably the kind of numbers we're going to see generally. There's a bit of a breakdown there for types of abuse. The majority of abuse for us still taking place in the adult's own home, followed by residential or nursing settings, followed by hospital settings. And the biggest type of risk being reported at the moment is neglect and acts of omission, followed by physical abuse. Now, although numbers are lower, domestic abuse as a proportion has gone up post-COVID. So previously it was about 9.6%. It's up around 11% at the moment. 11.1%, sorry. Oh, 11.8 it says there for quarter two, but at the moment it's currently 11.1. So as a proportion, although numbers are lower, as a proportion, domestic abuse has increased this year, generally, on cases reported. We talked a little bit about residential and nursing. At the moment, we're not seeing as much an effect on adults 18 to 64 going into new residential and nursing placements. So we're about 11.2%, so it's above target, which was 11, and it's good to be low on this one. But we've seen less of an effect of COVID at the moment on adults going into residential and nursing places. Obviously, a lot lower numbers than they are in adults aged 65 and over, but not much of a change here. You can see a bit of a breakdown there, and it's mental health clients that are a larger number so far this year going into residential and nursing placements, whereas our kind of ADS teams numbers are quite low currently. And as a reminder on this indicator, I'll try not to confuse things here, because of the shift between activity being put on the system, we tend to do this a quarter in arrears. So at the moment, we're looking at quarter one, and we kind of expand that up to the year end to give us a picture of where we might be at the end of the year. So at the moment it's looking quarter one, and when we come next time, it will look at up to the end of quarter two to try and get a real picture of how we might perform by year end. I hope that makes sense.
So the significance there is around the mental health, isn't it? The mental health placements.
Yeah. Yeah.
Okay. Thank you.
Now, adults age 65 and over, I'll explain this slide because this has seen a significant effect. Now, placements are increasing. New placements into residential nursing are increasing. But at the moment, we're projecting almost half of what we would have had last year. Now, that is in part, and we're thinking around the kind of discharge to assess pathway and possible delays of people getting into the residential placements who would have been there a bit quicker. But also just unfortunately increases in adults passing away, coming out of hospital and so on and so forth, has seen that kind of reduction. What we've tried to do here, given that kind of discharge to assess pathway bit, and it's this section here with the 50 in the circle, is get an idea of the number of people going through those pathways that are then ending up in new residential nursing placements. So roughly, given what was going through the process in quarter one, in actual placements we've seen, plus trying to get a bit of a flavour of those adults on those discharge to assess pathways, we're kind of assuming that at the moment that roughly about 50 clients come out and end up in a new placement. And if that were the case, given what's gone so far this year, we probably project about 370 admissions per 100,000 rather than 250. More than happy to try and talk that through once we get to the end of this and we're taking questions. But numbers are that bit lower at the moment than we've seen previously for a number of reasons at the moment. And this one I will go through slightly, but like I say, Colby's here, so he'll talk a little bit more through it, because there's normally prior to COVID, we're doing a kind of what I'd say was a normal internal process in assessing residential and nursing homes. That's kind of slightly different at the moment. I'll leave Colby to talk about that in a bit more detail. But what I've done on this slide is just talk a bit about the process in the commentary, or commissioning and fed back a bit about the process going on at the moment. But I've also included later CQC scores for our residential and nursing homes. So later score is any score for the care homes that have had, regardless of when that took place. And then the one on the right there is looking at the last 12 months and the latest scores between August, and that update was up to the end of August, just to get a flavour of performance against the CQC scoring at the moment. Makes sense.
Okay, Alex, that's great. Thank you. I wonder, I think I've raised this before, but the significant drop in the number of CQC presentations, good or outstanding, but would you like to comment on that, because that's quite stark? I think I know what the answer is, but I'm going to ask it as a question.
And I'll feel free, Colby can feel free to jump in here. There is an assumption that there are less taking place at the moment. There is a lot less, which is why I've done that kind of view of the current scores for everybody and the kind of last 12 months. Similar to our own internal processes, there is a lot less taking place. I can't comment too much because I've not got as much detail. I know Coolbeer might be able to jump in, not to put him in
there.
the...
We'll let Coolbeer do that. Coolbeer Lally, by the way, panel, and for those, is one of our senior commissioning managers and head of integrated accommodation. So you and Coolbeer, I can see you're in the meeting, so welcome. Thank you.
Thank you.
I think what we'll do is we'll have Coolbeer's presentation of Coolbeer's comments on the care standards, and he might want to just pick up the comment from my question, and then we'll take questions. Okay. Thank you. Thanks, Alex. And just one second. I think if members are asking questions about the performance monitor, maybe you can share your screen when we come to questions. That or is that not possible? You're on mute, Alex. Sorry. Alex, you're muted.
Sorry, I apologise about that. I assumed I was sharing screen there the whole way through, so my apologies. As soon as Coolbeer's done his bit, I'll bring the performance monitor back up on screen and we can go through it bit by bit.
That's fine. I think members, I suspect, have got it on another screen at home, so that's probably not the end of the world. But it'd be useful for the questions. That'd be helpful. Thank you, Coolbeer.
Thank you, Chairman. Do you want me to pick up the monitoring bit first in terms of your question regarding CQC first before I?
Yeah, that would be helpful. Thank you.
Not a problem. I think fundamentally, I think there is a huge reduction in what CQC have been doing since the start of the pandemic, but we have got that relationship with them in the meantime, so they are relying a lot on what we are doing to inform their decision making about which services they do visit and which services they don't. But we've got the local governance set up that allows us to share that data and information and help CQC target their assessments to the areas that need them the most.
There we are. Thank you. And my understanding, a real focus on those where there are concerns, and therefore skewing perhaps the normality of an inspection regime. Okay, absolutely. Thank you. Yeah, that's lovely. Coolbeer. Right. So, care. How are we doing?
Good. Thank you. So just want to give a brief update on the Adult Social Care Commissioning Dashboard, which ties into some of the conversation that's already been had at the beginning of the panel around the performance of the market as a whole across a number of different areas, across residential nursing, support for adults with disabilities, mental health, and community support commissioning and things like home care as well. So the dashboard covers the entirety of the commissioning market. And the dashboard focuses on three key areas: quality, which is obviously a key one, and we've discussed that very briefly already. What the market condition is in terms of risk, sustainability, and capacity, just to make sure that the market is operating in the way that we'd expect it to, but also to minimise the risk of provider failure as well, and also looking at cost. To take into account value for money, and also outcomes for individuals using services. Now, the dashboard is normally updated every quarter, so some of the data in it, as Alec has mentioned with his performance report, will be slightly out of date already. I think it was prepared at some point in September. So some things will have changed since then. And I'd welcome Cabinet panel to kind of just note the performance of the market as we go through, identify any specific areas of interest or where there's further clarity required, but also to provide a bit of steer for future dashboards for Q3 and 4. I'm not going to go through the detail of every single graph and the narrative. What I want to do is pick out some key elements across a number of different commissioned areas. And I'll pick up monitoring as a whole at the end. So across commissioning services for adults with disabilities, key areas of focus have been around day services. And over Q1 and 2, capacity of day services had been reduced as expected in response to the pandemic, with some services being closed and others running at significantly lower than normal capacity. Now, many of those have adapted over those 2 quarters to offer alternative provision, either virtually or as outreach, and others have managed to remain operational with COVID secure spaces to open for a limited and reduced number of people. Particularly in Q2, some of those services that were closed, we began to see reopen, and others we saw beginning to increase the certain numbers of placements they're able to offer. And significantly, what has changed, particularly as we go through into Q3, is that supported living services had stable capacity throughout Q2 and 1, and very few or significantly fewer COVID outbreaks than residential services. Now, unfortunately, that trend is changing. We are starting to get more supported living services that have been subject to outbreaks, and that is in line with the picture across Hertfordshire and the South East in particular, with the number of increases in cases, and that's being managed through the governance that we've put in place through COVID in partnership with our CCG and public health partners as well. For residential and nursing care, some of the key headlines. The pandemic has driven large-scale procurement of beds to be able to support the hospital discharges, and those are discharged to assess beds. And the large volume of those beds accounts for the particularly high spend on these pathways, and is likely to have impacted on the long stay placements in some areas. So that could be delaying transfer into long stay services or preventing admissions into long stay services. And that resource, again, is managed collectively with chief finance officers from across the local authority and the CCGs to make sure that we're delivering the right support in the right areas and that we're delivering value for money. We've also started an interim monitoring approach, which has been implemented in Q2. So we had to stand staff down during Q1 because it wasn't safe to visit services in the normal way. And we've put an interim approach in that's kicked off in Q2. And some of the data in the report obviously will have now changed, but at the time of writing, nearly a quarter of our commissioned services had received some sort of monitoring assessment, although not face-to-face. And additional officers have also been recruited to be able to get through the backlog of providers because of the time lost through the beginning of the year. Moving on to home care, uncovered care packages at the end of Q2 has reduced significantly with the same period in previous years, and that's seen a reduction to 75 in Q2 this year compared to 192 in the same period last year. During the first lockdown in Q1, that uncovered figure dropped right the way down to 42, but demand has now been increasing in particular hotspot areas, but it's not consistent county-wide, and that is due to people obviously not wanting what might be perceived as strangers coming into their home in the middle of a pandemic. 83% of home care providers are rated good or excellent, and 90% of our service users are placed within those organisations as well. So it's a big chunk of our provision is rated good or excellent, and 95% of all our service users have been contacted during Q2 with many reporting that they're satisfied with the care that they're receiving. So there hasn't been any significant complaints that we need to flag up. Utilisation of the purchased specialist care at home has increased, and that is in line with the discharge to assess beds that we've purchased also. It's another part of the pathway to support people to return home as quickly as possible from following hospital discharge, and that has naturally increased, as has the specialist care at home as well. So that's gone from just under 700 service users in Q1 to over 800 in Q2 as well. And Finally, in terms of the commissioned market with mental health services, HPFT are working with our monitoring officers within the county council to roll out the monitoring arrangements that have been agreed, to take an interim approach, and had some service users or a few service users in settings that were high risk in terms of quality or failure. All three have now been moved to be able to support their ongoing care needs, which has been managed really, really well. The final bit I want to focus on is around the risk management, which is going into a bit more detail around the monitoring that has been put in place and a bit of an overview of what that looks like. So I've mentioned before that site visits aren't taking place because it's not safe for our staff, but also service users for that to happen. However, weekly contact is being made with every provider across Hertfordshire. And that is to gain assurance that they are fully supported and accessing all the national support that's on offer, all the local financial support, but also the local operational and clinical support as well. And to discuss with the managers of those services any issues or concerns they may have. So however small or large, we try and collate that information to be able to respond effectively. We then group providers into various different risk categories, low, medium, high, and high risk providers, or where we're feeling that concerns are reported enough sort of medium risk services. We collect that information on a template, which looks in specific details at particular areas, and then mobilising the correct resources across the health and social care system to be able to respond where possible. So that might include things like district nurse support going in. And we've also put into place interim arrangements, which is putting together the various different intelligence that different partners across the system are picking up, including GPs as well, and linking in with CQC, as I mentioned earlier. We've combined some mandatory questions from our normal monitoring tools that we would have done face-to-face, plus feedback from staff, residents and family members, and all of that is supported by a virtual tour of the setting. So that's where technology has come into its own. We've been able to speak with managers and the managers to take us around the home virtually to be able to respond to some of the concerns. And this provides an indicative quality score, which is very similar to our normal processes, but obviously it's an indicative because we haven't had the eyes and ears on the ground. But what that does is it creates an action plan for that service to follow, which is in addition to what they would have had from us at our previous visit, face-to-face visit, and gives us assurance that the necessary remedial actions are in place. And then our business as usual processes kick in place around that sit under the Hertfordshire Safeguarding Adults Board if there are significant and ongoing concerns that may impact service user safety. And those processes behind the scenes are working with providers to be able to put some proper governance and system support around that and hold providers to account where necessary. So thank you.
Thank you, Corbia. Panel, there's a lot to take in there, and I should also just point out that the local report, local account, I should say, is beautifully presented, has got some fabulous information there, which covers the last 2 years. So whilst we have the performance report, which is now and obviously reflective of COVID, we also have the local account, which gives a kind of broader context for how services have been performing over the last couple of years. But I have a number of members wishing to speak and ask questions, and I think we can probably share screens if you want specific information about specific subjects, and we'll try and do that. Thank you, Alex. That's good. So first of all, I've got Ron, then William, then Nigel.
Thank you, Chair. I'd like to go to the local account, page 14, and note about the 169 million on disability services, which applies to learning difficulties. But I don't see any category for physical disability expenditure. And that isn't also that, neither is that explained or covered in the glossary.
Yep, I believe it's both, but Alex?
Yeah, it will be both, but if we can clarify that if you like, because although this is pretty much a finished product, we're still going through and making it accessible. So anything there that we think needs a bit more explanation, we can do that.
Yeah, because if you turn to page 17 and you look adult disability service, it mentions who have a learning disability and are not able, etc. So it has no mention of physical disabilities whatsoever.
Yeah, noted. I can make that change.
So they possibly, because they do require totally different services in some cases, you may want to consider having them as separate items.
Okay, good point, Ron. Thank you.
Yeah, and the only other one I've got at the moment is on page 8 of the safeguarding concerns, and I note the 34.5% physical abuse. And there's no comparison on previous year. Is that an increase or a decrease on last year?
I can look. I shall look that up as we speak. Yes, there's no comparison there. I'll look that up as we speak just to double check.
I do know that the COVID and the lockdown has had an impact on domestic abuse, and I would have thought possibly that there is a same trend there which we need to worry about and need to perhaps pay attention to.
Yeah. I'll have a little look at that while we speak, and I'll feed that back into the chat. If that's easiest.
Thanks very much. Thanks, Chair.
Thank you, Ron. William.
Thank you, Chair. Well, Ron's picked up the point about classification of disabilities, so that's good. That's one out of the way. I'd also like to ask about 1.2, which is the 91-day measure. Not anything specific about it, but simply to ask whether or not you do any sort of post-mortem, as it were, of those who are going back into hospital, and whether or not you can detect possible poor preparation in hospital or poor treatment, and then report it back to the hospitals. Would you do that sort of thing?
I know Chris has got his hand up, so I don't know if Chris, are you going to jump in there?
Yeah, if I can answer that. Yeah, we don't do that wholly systematically. So we do that, clearly with service users. Our hospital teams will recognise, because they'll have been working with that individual relatively recently, if there's a quick readmission. So there'd be some learning on that would take place dynamically. What we're trying to do, William, actually, is put in some more qualitative measures around this. So we do a lot around measuring, for example, how many people are delayed, how many people have stayed a certain amount of time in hospital, and then the readmission rates. What we're less good at doing, and we're trying to put some work in around it, is what the qualitative measures are. So how was that discharge experience for you in terms of how you were supported or how your member of family was supported? But I think it's a fair challenge that we could do some more systematic work around readmissions. But I'd be keen, and NHS colleagues do a lot of that, and they have various codes that they can do to break that down, that you'll be aware of, William, no doubt, from your role as governor. I think it's a fair challenge around whether we could begin to look at that again to understand what themes there might be. And that's something I can ask probably Tom and Helen, it's primarily an older people's issue, this, to do some work around, just to sort of do some sampling of that. So I think that's a helpful challenge.
Thank you.
Thank you. Thank you, William. Really, really helpful. Nigel.
Thank you, Richard. And thanks both for excellent reports. I don't want to single anybody out, but Alex's graphics were very, very good indeed. Much appreciated. I don't know what size screen Corbier has, but I was struggling to read everything on his report on mine. But anyway, there's a lot of very, very useful information there. I've got a couple of questions on the performance report. If we go to 1.7, which is Agenda Pack page 50. So a significant proportion of the admissions were adults requiring mental health support. Is that an unusually high proportion, or is that normal? Do you want to just go through one by one rather than listing them all? I've got about 3 or 4, Richard.
Yeah, I think that's a good idea. Thank you.
Yeah. Yes, they are high. There is work ongoing. I don't know if Helen and Chris can jump in here if they feel they need to, around what's better around supported living settings. So obviously from the ADS perspective, supported living settings are preferable to obviously a residential or nursing setting, and they're working through that with the kind of mental health approach to things. HPFT are taking on Connected Lives in the next year or so, which will help, and we're kind of making sure there's a greater focus on those kind of residential admissions and choices that they're providing there. It is a bit of an increase by this point in the year, so we've been investigating that with HPFT directly and through what is our partnership operational group to monitor that closely. So we're hopefully getting some feedback shortly about those particular cases. So we should have some feedback.
Thanks, because I think the capacity in residential mental health is not high, is it? As I know from casework where it's been difficult finding places for people.
Yeah, and I think, sorry if I can just chip in now, and I think clearly what we're always trying to do is wherever possible support people in the community. So we've got some work ongoing with Hertfordshire Partnership Trust as well around how we can develop some reablement facilities as well. So we've got individuals that we can look to support in a kind of reabling function with a shorter term admission to a service to then help individuals then maintain independence later. On that supported living point as well, the wider supported living work, there's a development of our supported living strategy going on at the minute, which involves close working with district and borough councils too around our provision around supported living, but also around what our capital programme is likely to need to be to look to improve our own supported living stock, where we own a number of assets already. So your point's well made, Nigel, and it's an area of significant focus for us.
Okay, thank you. If we go to 1.9,
just one other thing, Nigel.
Mm-hmm.
I don't know whether you're listening, but Tom Carver in the Health Wellbeing Board recently was talking about mental health acuity being there being a greater need, and that being presenting as well. So that is one of the outcomes of COVID is a greater demand on HPFT services, and I think that is in the mix as well. But thank you.
Yeah, I think that's very true. Unfortunately, I wasn't able to attend the last HWB. The 1.9. I think there must be a misprint here somewhere. The sort of the orange thumb is inadequate, and I always thought inadequate was below requires improvement, but maybe that if you just clarify that. But the key thing on this one obviously is we're obviously, it sounds from what both of you have said that we are focusing our monitoring and active engagement on the places that most need it. I just wondered if you could comment any further on that. Just to state probably the blindingly obvious that we are more in contact with that 22.8%.
I think that's helpful to ask it in that way, Nigel. Let's just state this in a very blunt way, because my understanding is what I said earlier. So let's just Alex or Chris, just to spell out that this is our minimal amount of active live monitoring, boots on the ground, is on our most where we would reflect we really need to be on the case of that particular provider, for example. But Chris or Alex.
Yeah, I mean, absolutely. And that's a pattern we normally see. So what you'll see is we'll prioritise, and then let's say without COVID, you have a situation where you monitor this quarterly. In a sense, every year, the percentage of requires improvement, so the percentage of good or outstanding expected in that year goes up as you go through the quarters, because quarter one, you're focusing on those that we've identified as high risk, and that goes down, so that you almost need to set a trajectory to understand where you should be at each quarter going towards that major target. I think the other thing to mention that I think Corbyn mentioned, but just to support really, is we are investing in extra monitoring officer resource because when restrictions begin to ease and we want to really understand where care providers are post-COVID, we want to accelerate our monitoring programme. And consequently, in preparation for that, Coolbeer will give me the numbers, but we've invested in extra monitoring officers to get us in a position ready to do that, because clearly we need to get them up to speed and so forth. Coolbeer, just remind me the number. I had 4 in my head, but
2, and I think the second one is starting next week, I think.
Okay, great.
Okay.
And finally, Richard, if I may,
please.
To COVID activity data. There's a huge amount of information on this, but I'm not entirely clear how it relates to COVID specifically. Are these stats for the entire picture, but just for the COVID period? And the one that sort of shouts out at you as a concern is the wait list on assessments, which has grown rather worryingly since April to October.
Yeah, so if I can answer that. So the idea with this is to show across all our activity metrics, which aren't always reflected in the performance metrics, is the impact that COVID had on all our sort of key metrics over that time period. So you'll have seen, you'll see a kind of dip and an up. It's almost in reverse proportion to the outbreak, as it were, because of the reason for lockdown. Yes, so the waiting list is a concern. It's clearly gone through a jump. So while it's high, it's about where it was, slightly above where it was in July last year. Clearly, we manage waiting lists in a certain way around risk rating people that come through. So if the needs are higher, we do a triage initially to do that. We know we've got some waiting times that we're not comfortable with in, for example, housing adaptations. And supporting people, that's been really difficult to get going because you've got to go into people's house to do things. The other main issue with the assessment waiting list is we're having to undertake a number of more assessments per person than I normally would. So if you look at a traditional hospital discharge where individuals have been supported to a kind of interim setting, what Coolbeer's referred to as discharge to assess setting, clearly we then need to do another assessment to secure a longer term placement. And that's taking a lot of staff time out, because linked to that, as well as a number of assessments we've had to do on the basis that there was a new regime around funding that came in around COVID, where NHS would support costs for a certain amount of time in March to September, and then from September onwards in the first 6 weeks. So we're having more contact points with people, and that's creating pressure. So we're working really closely on that. We've fired money from the care purchasing budget, which we're have a little bit of wiggle room into staffing budgets to try and address this. So we've taken action in year to try and move resource to do that. Clearly, we've still got constraints about how we can undertake assessments because of the COVID restrictions, but we're managing the risk within those waiting list assessments, I think, coherently, albeit we're working hard to get them down.
I did say lastly, didn't I, Richard? But I have got one more if you'll grant me the leave to raise it.
You're on mute, Richard. I'll take that. That was a.
Is that a yes? I'll take it as a yes. Okay. On the annual report, I just wanted to note that we are in the annual report on pages 5 and 7, I think it is, which are the measures of success. We do have a number of metrics there where in 1920, pre-COVID, we were considerably down on the target. Inquiries being successfully resolved was the one on page 5, and then proportion of adults with a learning disability in paid employment, which I know is a very difficult one, being proportion of older people being offered re-enablement services is quite considerably down on the target. It's about 60% of the target, and we're also down on the proportion of older people still at home 91 days, although that seems to have improved recently. Just wanted to note those and just get your comments, probably more for Richard and Chris than anyone else.
want to come in, Richard, first?
Yeah, Chris, yeah.
Yeah, on the enablement, yeah, we're clearly, we've had a number of bits of work that say, clearly it's much better for more people to have that clear enablement pathway than it is others. There is a slight counting issue here in terms of what we count as enablement, and I think we take a particularly strict view compared to some other places. But what I would say on that is you saw in Coolbeer's report on care standards this year, the increase in people being supported by specialist care at home providers, which is essentially the enablement service. I think they've gone up from like 600 to 800 broadly. Key to that, I suppose, is workforce. Ultimately, this is a workforce issue, so it's not that we haven't got enough people to identify for enablement, it's the workforce issue to do that. So that and the reduction in the uncovered list that's highlighted in Coolbeer's report should give us some confidence that that figure will improve, because essentially we've got more capacity in the system. But you're absolutely right that it was that inability to secure enough enablement that led us to make some of the decisions around investment proposals that we gave to members. The signposting one is a bit more nuanced, really. We want to do more on the signposting levels to try and support people earlier and get them in a sense to think about support that there might be in the community ahead of accessing formal support. Just got some comparative data through on that as well, which we'll use. I think the key to this may be, because we need to do better on it, is what the learning from COVID has been in terms of the voluntary sector, how we're utilising Hearts Out really effectively, and what other community support has been made quite apparent through the way that people have stepped up in COVID. And I suspect the challenge for us will be to ensure there's a lasting legacy around the voluntary sector and community support that will help us with these indicators by helping people. And I think we're looking to come to panel in February with an update on our initial thinking on a longer term voluntary care strategy to build on the COVID legacy and proposals, I suspect, in the integrated plan around investment in that area. And it's targeted at just this stuff, Nigel, because this is really the preventative end of our work. And if we get this right, it reduces longer term care dependency and, of course, associated cost.
Exactly.
Thanks for that, Chris. Thanks for raising that, Nigel. It's absolutely right that we look back before COVID and we look at what COVID has done and our response to that, which has been huge, to be honest, with our partners. And I think there is when we come out of COVID, I think there is a huge challenge to make sure that we have, as Chris says, we've picked up on where things have improved and we've embedded that, but actually really challenge ourselves around performance, and that where we spend money, that we've got an outcome that we were expecting, or why didn't we get the outcome we were expecting? So I think it is a perfectly legitimate challenge. And I'm quite happy we'll get the vol sector when we bring a paper, and I guess we'll probably bring it will be next after Christmas, it'll be February. So because that has been that partnership work with both statutory and health and vol sector has got us through this pandemic. I've been reflecting on that as I'm sure you guys have as well. It's been a really positive experience, and we need to make sure that's picked up for next year as well. Okay, that's great. Thank you for those questions. Now then, Nigel, you seem to have been asking questions for about the last couple of hours. So I'm just checking, was there anybody else who wanted to come in? I think I've got Drida. Thank you, Drida.
Yes, thank you. And many of the points that I would have raised have already been covered, so there's no need to go over those again. And I thank the officers for bringing forward this presentation. My query really is over 1.1, which you will know, Chair, is an area of particular interest to me. It's the proportion of adults with a learning disability in employment, mainly because I do like to track the opportunities that are out there for my ex-pupils. And as Nigel and as the report lays out, there are significant difficulties, obviously, in this area that I think we all acknowledge. And I would hope that at some point there will be some national initiative, perhaps with incentives for employers, in order to increase the percentage of people with learning difficulties that are in actual employment. Now, when we're talking about employment, I wondered if the officer could explain perhaps the figures, because some of them allude to paid employment. In the report, it says we have supported 3,001 learning disability clients with a long-term service. 187 of these clients are in paid employment. And then in the same paragraph, it goes on to say about other employment in particular groups, but it doesn't say actually whether that's paid or not. So I'd like a bit of clarification there. And also at the end of the report, it says that there's a transformation program has been employed, My Future Coach, as a new way of working, applying TSI approaches. I didn't know what TSI meant, and I just was looking for some clarification on that. But as I say, I do think that this is not a problem just within Hertfordshire, and it does need a national approach. So I hope at some point that we'll be able to push for that, because employment opportunities, particularly amongst the younger age group, are going to significantly worsen. And I believe in the 18 to 25 group, they currently run at about 14%. So that's really very worrying. Thank you, Chair.
Drida, I think we can almost judge ourselves as an organisation on how we do in this area. I think it's always been a challenge, and it kind of goes to the heart of how do we give independence to those with learning and physical disabilities? How do we give the opportunity to develop and to support our cohort so that they have the confidence to live on their own, to get out and about in the community? That may be paid employment, but it may also be volunteering opportunities, and it may be also just where within our own family of support can we do more. So, for example, just a really good example that I've seen recently, our clients working with the Commission to work with the Sunnyside Rural Trust, and then local parish councils taking on those with learning disabilities, supported to be there, doing village warden type work. Really brilliant, and thoroughly enjoying it and doing a good job as well. So there are real opportunities out there in that mix of community activity, volunteering and paid employment. And I think it's absolutely right that we're held to account on this. Chris, you wanted to come in?
Yeah, I'm afraid, Drida, I don't know the acronym TSI. Apologies for that. We'll get that altered, and Alex may have Googled it or found out quickly.
I do have the answer, so once you've chatted, I'll tell you.
Okay, good, thank you. We've actually agreed as a panel, I think last time, that we'd bring a sort of in-depth deep dive report into learning disability employment opportunities, I think in the new year, to go through in some detail, because it's an important area. I'm also conscious that when we look at the services that we also provide ourselves, that there's a focus on employment in that as a means to independence. So, for example, when we look at our own day services and supported living services, how that interacts, but also clearly panel signed off the community opportunity strategy last time round, which talked about developing models of opportunities in the daytime for people with learning disability that had a clearer focus on employment. So, couple of measures there, and I don't think it's a great measure actually. The measure that's set here nationally, when we've got a report against it, I think we might want to look at some better, more nuanced local measures around this too, to chart progress, because it's an area that we really need to prioritise. I think it's likely as we develop our 3-year plan, which is getting developed as we speak and consulted on and engaged with, I think this will be quite prominent in that, Drida. So have a look out for that when that comes, because I think you'll want to challenge us to make sure it's there.
Thank you.
Thank you for that, Chris. I've got that's Drida. Just that covers some really important strategic work right across that, valuing independence. all of our day service type provision, our day opportunity provision, are supported into employment and volunteering. I think there's a big range of stuff there that will definitely need to come back to panel, and I think is a huge development opportunity for the county council and for adult social care. Really good. Right. Now then, 1 second. Oh yes, Dave Hewitt wants a break. Okay, got it. Absolutely. So I had no further indicators. Alex Coolbeer and all the guys that helped put this report together, thank you so much. Really, as Nigel said, really clearly sets out what's going on, and also helpful to understand that we're starting to get a better picture now of the influence of COVID and where the normality lies. That's really helpful, and that's gives us confidence that we know the direction of travel with so much of with our client base. Really helpful. Okay, so it remains for me to ask you. Somebody's trying to come in. No. So Coolbeer.
Yeah, just wanted to just address Nigel's point earlier around the size of the text. Just to make panel aware that we're looking at the accessibility of the data on the dashboard. So the next iteration should hopefully be much easier to read.
Thanks, Coolbeer. Yeah, they're great. that would be really helpful. Thank you. Ron, another one there. Well, wrapping up. Come on, Ron, right in the middle.
Just as a matter of interest, and I'm sure it would be interest to everybody. I think it would be useful, not necessarily as an extra page on the report, but at the next cabinet panel and perhaps for the next one or two, if we could have a similar type report on the vaccination programme in care homes and in the domiciliary services, our users there, just to keep us up to date on. Are we tracking it?
No problem, Ron. We can do that. Yep, good idea. Excellent idea. Thank you. Right. So panel, we've recorded your comments. They will influence how we run our services. That's appreciated. I've given thanks to those who've contributed. I ask you to ideally agree or in the chat function as to whether you accept this report. Okay. Yeah, that's unanimously agreed. That's fantastic. Thank you. We will now take a 5 or 6 minute break. It's 11:57 according with my clock. So let's get going at 5 past. Thank you very much.
Richard Wood Live.
Thank you very much. It's good to be back. It's a little break from the screen, which is what was needed. Thank you very much for those who want us to crack on. So thank you so much for the performance, and then of course the Heartscare Standard Dashboard, which Kulveer presented, and really impressed with that. We're going to crack on now with agenda item 6, which is the Hertfordshire Dementia Strategy. Some very specific circumstances here that I'd like to get Helen to introduce the paper, and then probably bringing in James Salmon. So Helen, over to you. Thank you.
Thank you, Chairman. I'm here with James, as you say, and also with Simon Patterson, and James and Simon have done a lot of the detailed work to pull this paper together. I've recently started chairing the Dementia Co-Production Board, and that's been a really interesting experience. It's a very well engaged board, and I know that board has had a really significant say in what this strategy that's before panel today, what this interim strategy is addressing. So, Chairman, this is a for information item. We felt it was particularly important to brief panel on our activities around dementia because, you know, regrettably at national level, people with dementia are being hugely affected, as we all know, by the pandemic, both in terms of mortality issues and also around how dementia can be accelerated by some of the stresses and isolation that the COVID period has brought. Just to step back a little, panel might be aware that the previous multi-agency strategy for dementia, which was 5 years in duration, was coming to an end. Yeah. And just before the start of the pandemic, partners across Hertfordshire had agreed to do an extensive public engagement exercise to get people's thoughts on what should be in the new strategy. Unfortunately, that had to be put on hold when COVID started. And then when the Dementia Co-Production Board reconvened after a period of not meeting back in July, the board took the view that, you know, COVID was making it so difficult for people that the immediate priority needed to be looking at the things that needed to be done to support people in the here and now. Yeah. And in due course, we can come back and look at what the longer term might look like. So this is a 1-year interim update. It went live in September, and this report updates panel on what's happened since September as of November 2020. Panel will probably feel familiar with a number of the themes that are in this report because it kind of echoes a lot of what was in the winter plan, which was brought to panel last time round. And also it overlaps significantly with work we're doing to support carers because, you know, obviously all this is very interlinked. So key areas of focus are around how we can support care home visiting, working safely within the national parameters, what we can do to get day services up and running again in a safe way. We're using our infection control funding to really try and address barriers there. Key elements about how we can support carers, what we can do to give carers breaks, different kinds of breaks because kind of residential breaks now are not as popular as they would have been pre-pandemic. And also importantly about encouraging people who might be feeling that they're starting to struggle with the first signs of dementia to sort of pick up on that and come forward for diagnostic support. So Chairman, I'll leave my brief intro there and hopefully between us we can answer the panel's questions. Thank you.
Could I ask James and Simon to introduce themselves so that panel are aware of that? I mean, I am, but I'd just like them to introduce themselves. That'd be great.
Yep, so I'm Simon Patterson. I head up the Integrated Health and Care Commissioning team, working across both CCGs and the County Council.
Thanks, Simon.
James Salmon, Senior Commissioning Manager in the Integrated Health and Care Commissioning team.
That's great. You're both welcome, and thank you for your paper. And Helen, thank you for your reflective introduction. Again, we see not only the impact of COVID, but how we've responded to COVID, and this impact continues well past this winter period. And therefore will be more than a year and possibly 18 months, even into 2 years before there will be a more normalised way for support to take place. But I think what we'll do is we will Can I just check, James or Simon, is there anything that you would like to say now before councillors ask questions, or are you quite happy to accept questions and then expand as we go on?
I think we're happy to accept questions.
Yep, lovely. That's great. In which case, I'm going to start with William, and then Ron, and then Drida.
Thank you, sir. Talking about dementia diagnosis rates in point 5.4, I did find in discussions with the Alzheimer's Society some years ago that they were very reluctant to let their official, as it were, test be self-administered. And I couldn't find any way in which a carer could get done at home any form of assessment that had validity in the eyes of other people. I'm simply suggesting that there ought to be such a test so that you can either self-test or your carer can test and take the load off people who aren't yet suffering from dementia and take them out of the system, albeit possibly temporarily. And also at least give you something to go on when you're asking for a test and perhaps get some sort of priority.
There's almost two parts to that, aren't there, William? There is, have we got something that would enable people to have a very good idea whether they've got dementia or not, and then perhaps before they go to get confirmation, but to give some people confidence that they won't have it, and whether that's available in the home, so to speak, before going to a GP. Any comment from Simon or James?
I mean, I think there are a number of reasons that people might be experiencing memory issues. So it's hard to get something that somebody could administer at home that I think we'd be confident in giving the sort of right sort of answer to that. I mean, it's people quite like diagnosing all sorts of conditions via Google, don't they? And the quality of that is not necessarily very good. So sorry, William, I'm not sure I'm giving you the answer you're looking for, but I think it is one where we do need a professional's advice about whether somebody has dementia or not. And we've seen fewer people come forward for that during COVID. I mean, inevitably at the start of COVID, there was that advice that everybody should avoid visiting the NHS if at all possible. But we've seen that carry on a bit. So we are looking to promote that again and get more people coming forward, because there will be more people with dementia that haven't come forward in the last few months that we'd like to give them the correct advice.
I can understand your I can understand the reason for the question, William. I do worry slightly that we diminish the nature of the disease. If you had a broken leg or a broken heart, you had a heart attack, you wouldn't hesitate to seek medical help. And I think it's perhaps the same message for those that maybe in the early stages of dementia, that actually get to the GP, get a diagnosis, and therefore allow you and your family to start the process of understanding how to deal with dementia. I think that's probably where I would fall on that one. James.
Yeah, just to say, some of the sort of diagnostic tests that form part of the diagnostic process are very straightforward and can be done at home, drawing the numbers on a clock one way and then backwards and other things like that. But we haven't provided sort of publicly any kind of pro forma for people to do that at home for exactly those reasons that have been said, and particularly the fact that dementia symptoms can be symptoms sometimes not of dementia, but of things like depression and other things that really affect older people, which really need, in the first instance, a general practitioner to kind of disentangle some of those things, and even to family members, that they can mistake one for the other quite easily, or physical things such as a urinary tract infection that can impair people's cognition. So we have taken very clearly that sort of go and see your GP or contact primary care in the first instance.
I think that's really helpful advice, and for both of you to expand on that there are any number of disease that may give similar expressions of what dementia might look like. So yes, clarification and certainty through the GP, and our message must be: do get in touch with your GP, do make an appointment, and create some certainty there. Thank you very much. Thank you for your question, William. Ron.
Thank you, Chair. Yeah, I'm concerned with the section 4 on page agenda page pack 97, the section on carers. I'm particularly interested in. It looks as if we're just actually getting going with counselling and with the and I just wondered where we are with the counselling offer. And also respite services. Are the respite services just sort of the ability to provide a space, a bed for the evening to give the carer a break, or are there any sort of minor, if not necessarily minor, because they are crucial in terms of the care of the carer, but say, for instance, a couple of hours off during the day to go to shopping so that the carer can go shopping or things like that. Is there any plan to work with Hearts Help and other voluntary organisations to provide a helping hand? Although obviously the people have got to be trained, because clearly dementia is not just sitting with someone with a broken leg. You've got to have the necessary skills for it. But you can see my drift of the questions.
Absolutely, Ron. So two parts to that, sort of counselling and then respite, and the different manifestations of respite, whether away in a day type centre or respite at home. And if you'd want to expand on that, I'd be grateful as well. Thank you, James.
Yeah, I'm happy to give a bit of information.
So you
about
got
that.
picked on because your hand was still up, but
yeah, no, I put it up because I might be able to help with that. So on the respite point, there are beds available for respite care. There are real challenges around people using them and accessing them, partly because of the kind of testing and quarantining regime that, of course, absolutely needs to be in place. So the idea of a loved one going into a respite home and then having to be effectively self-isolating in there for a period of time, that's obviously a very difficult situation for people to be in. So there are real challenges around that, although it is something that is available and is being used for some people. We have particularly been asked by Carers in Hearts to look at expanding the offer of respite within people's own home, that may be a more kind of acceptable offer people to take up, and so we have a number of commission services that provide that, both pre a formal carers assessment and post a carers assessment on the care act, and there are capacity in those services, and they are being used. We're doing some comms at the moment to ramp up the take up among people of the pre-carers assessment break, and in the last few weeks that has risen by about 30%. So it's good news that more people now seem to be feeling that they are able to come forward and accept that. We've also heard of reports that particularly in rural areas, there are some areas where people are waiting and have been struggling to get breaks and respite in the home, and so we've recently, ACS&B have approved an expansion of our service to give the provider a small block to help them, to give them the capacity to get people to go and cover those bit more rural areas. So we are hoping that it's a mix of growing the capacity, but also reassuring people that it is safe for them to access these services. So we're working on both of those at this time and rolling that out.
Thanks very much.
Thank you. One of those providers is Turning Point, isn't it? For what? And the other one is
Crossroads.
Crossroads, yeah.
And Crossroads is the one that we've expanded a bit recently.
Yeah, that's I picked up the significant uptake of that in November, and obviously that's reflected in your efforts as well. That's excellent. Thank you. Drida, then Nigel.
Yes, thank you, Chair. I have a concern about monitoring, if you like. Quite often, people with dementia who are living at home, and dementia is quite a wide spectrum as an illness, isn't it? You know, we class it in one term, I suppose, but it's a progressive illness, and you can be anywhere kind of on that spectrum with the condition, but quite often it's elderly people or people that have their own vulnerabilities that may be looking after somebody with dementia at home, and I just wonder how we can intervene, if you like, to make sure that both parties have the support that they need, because as dementia, as it gets progressive, obviously the needs change, and I just want to make sure that there are checks and balances in place to make sure, as I say, that the person with dementia is getting the right level of care and the person looking after them is getting the right level of support.
Absolutely, Drida. Great question. A comment from Simon or James?
Although I think Chris has got his hand up, so I wondered if he
wants. Oh, my apologies. Chris, did you want to come in?
Yeah, I was just going to pick that point up from Drida, actually, and I'm sure Simon and James will add to this, but just in the point of care, the carer in this situation, I think it's a really good example of why it's really important to have good carers contingency plans, because sadly we know that dementia can be can get progressively more acute, and therefore the challenge on both the individual with dementia and those that care for them can increase. But when we know that is a possibility, there's something important about getting some future planning and contingency plans in place to understand how the support to that individual might change and how indeed the support to the carer might change. So COVID's really shone a light on this for us because of what happened. So we're working quite hard to up our game really on how we offer contingency plans, support people and think through the future with people when we do the carers assessments, which we mentioned earlier, because I think it's a really good point, Drida, about doing, thinking that things can change in this scenario quite quickly, and for us to really be supporting people to be thinking about the future.
Yeah, thank you, Chris. I have to say that wasn't a million miles away from an answer I might have given myself, and it almost comes back to William's point earlier about the sooner we have a diagnosis, the sooner the planning for progression of the disease can be taken into account. And therefore, and almost the capacity and the capability of the care in the home, and then what support we need to give. That's obviously really pertinent to the quality of the journey with the disease. So, Drida, that's spot on. I think that we should. I appreciate it's in the report, but I think we should just hold that point around contingency planning, both for the cared for and the carer. And of course we do again, perhaps Simon or James might want to comment here. We support directly some 500 or 600 carers, and in reality, to give some comfort to panel, would this be a good example of how we would support carers to be able to do more caring?
I don't know, just a reflection from me on that, echoing everything you were saying, really, and also that carers, obviously, once again, it's just something about identifying that you actually are a carer, and then And then, you know, there's an opportunity then to have a carers assessment and for us to think about how we can best support you. So again, encouraging carers to recognise that they perhaps are in that situation is important for us, what part of our strategy. The other thing I was going to say about what we've been doing during COVID is to really try and reach out proactively to people. So just to try and get those operational teams calling out where they've got people on their radar they might be worried about, just to check in proactively, have those discussions about how they're getting on and what we can do to support. And obviously, I know the panel's very well aware that through things like Operation Sustain, we've been really trying to get the word out about how to access support, even if you're not on our radar, so to speak.
Yeah, that. Thank you, Helen. And that information, advice and guidance, it's not always about money, but it is some reassurance about where you can seek help. And again, coming back to the point was made earlier, Hearts Help may be a great place to turn to for advice and guidance and introductions to organisations who may be able to help you, and you can engage with them. And it is that is pervasive through what we do, through the, if you like, the preventative agenda. So thank you, Helen. James.
Yeah, just very briefly, just to pick up on Helen's point and expression about people that perhaps are not on the radar, as it were, and I think that's very much what the Co-Production Board have highlighted, and voluntary sector organisations have highlighted, that the service users and their carers who are at the top of the lists of risk profiling are often, you know, people who are already in touch with services and receiving support, and it's the people that are supporting a spouse or a loved one by themselves, largely without drawing on other services, and perhaps have done so for many years, but who, through perhaps the effect of lockdown partly, but the deterioration as well, who then find themselves in a really difficult situation, perhaps quite suddenly, and they don't have that network around them to draw on. And that is the bit that one of the cohorts that we're really worried about. And so we're pushing out very soon some communications, particularly through primary care. Primary care, as you can imagine, are extremely busy at the moment. But we are going to try and work to push out those communications to encourage that primary care do kind of reflect with patients, with people that they may know of, to make sure that they get into these pathways and people do access this support, because they may not be known to social services.
Thank you, James. Drita, excellent question, and a good challenging debate for us all to think about. Really helpful. Nigel.
Thank you, Richard. Yeah, I apologies if this has already been addressed. I had to take a delivery at the door whilst William was asking his question. So I was going to ask about carers and visits to care homes. It doesn't just apply to dementia patients, but it particularly applies to them. Where did we get to with the idea of accelerated tests or regular tests for a designated carer in that person's bubble?
No, so first of all, we haven't covered this. It's perfectly apposite that we should cover this. And I've got Chris indicating he'd come in first. Chris.
Yeah, it's a good point, Nigel. As you say, this is a particularly difficult issue for individuals caring for people with dementia, but a much wider issue, as you say. So where we've got to on that, some new government guidance out a couple of weeks ago on visiting. Couple of changes to that. One was a suggestion that it was advisable that you could have two visitors or two different visitors per resident, rather than advice around one, which I think was a welcome change. Ultimately, the guidance still says that it's up to the individual care home around making that assessment themselves based on a number of factors. But I suppose the big change has been advice around how sort of more indoor visits and visits without things like the Perspex screens and other arrangements that have been put in place, how they can happen safely. And that's where the lateral tests come in, the so-called lateral flow tests. So the position that we've taken in terms of advice that needs to come from myself as director and Jim as director of public health is to suggest to care homes, number one, really important if you want to use these, that you undertake the training, which is made available by the Department of Health and Social Care, and that you make all the right planning arrangements to allow this to happen. It's not straightforward because people have to undertake tests in a certain room. It's probably easier for bigger care homes than it is for smaller care homes, and we'd rather people got it right. Our advice has been, while the effectiveness of the tests is still, I think, being clarified, it's fair to say scientifically, our view is it's a good addition to risk management approach. We believe it is a way that more visiting can be facilitated. We believe the risk of infection and the outbreak need to be balanced around the mental health and well-being of residents and their carers. So the view that Jim and I came to was we would support their use to facilitate visits within the care home, as long as PPE continue to be used and other precautionary measures were taken. So it's not sort of carte blanche, just keep visiting as we did before the pandemic, but we do think it is a way of, in a proportionate way, allowing more visiting to take place. Now that's within the gift of individual care homes around their decisions to do that. We've been encouraging, we've offered support, webinars, etc., to encourage that uptake. And Richard, myself and colleagues from the management board have met a couple of times with the Carers in Hearts, the Alzheimer's Society and Age UK, just to keep them updated on what we're doing. We've sought some feedback from individuals who are caring for individuals and that have got loved ones in care homes, and it's pretty clearly a very traumatic issue. So that's the approach we've taken, which we hope facilitates more visits, and we've aimed to put that support into care homes to allow them to do that. But it's important that we have some patience around that, because I'd rather they got it right and did the planning rather than necessarily go into it too quickly without having thought through all the process, the staffing requirement, etc., and the comms to make it happen safely.
Thanks, Chris. Just if I understood correctly, so that we're talking there about lateral flow tests for potential visitors. Mm-hmm. What we were discussing, gosh, must be 3 months ago almost now, was the proposal that was being pushed by, I can't remember which organisations, a lot of people, to introduce weekly PCR tests for a designated carer for a resident, in the same way that care staff were being tested from September-ish. Has that idea fallen away now?
Well, it's not been taken forward, and the view, in a sense, I think, because the idea that the facilitation of visits and support that lateral flow tests might deliver, probably to a lesser intensity per individual, because it provides less assurance, but is easier to give out to more people, has taken precedence at this stage. So I think the PCR test is still being looked at in terms of how that can work. But I suspect at the minute the focus will be on lateral flow testing and, of course, deployment of vaccine. And it's around also, what we're conscious of at the minute is the capacity within care homes to respond to these different streams. So at the minute, it's not progressed, but the lateral flow testing has progressed probably more quickly than we thought.
And that's in the hands of who, the PCR thing? Would that be Public Health England or?
Department of Health and Public Health, because it relates to things like testing capacity and other elements. So that's where that decision sits. It's not within us.
Right. No, I can certainly see the temptation to get everybody vaccinated as quickly as possible, so that removes the risk.
Thank you, Nigel. I'm aware of. Just echoing what Chris has said. I think it was Helen Whatley, the social care minister, who raised this, where PCR was the only game in town, and it was pretty much felt that this might introduce too big a risk into care homes as a way forward to have a very large number of visitors, but only based on weekly testing. Whereas the lateral flow test, which can take up to an hour to administer, whilst it's imperfect, it's part of that armoury. And I think that carers and family who want to visit those, particularly over Christmas, but at any time now really, should take up that opportunity. My understanding, I stand to be corrected, is efficacy is only about 55%, but for those that have got a heavy dose of COVID, it can pick up more like 70%. So the more infectious an individual, the more likely that the lateral flow will pick it up. And then if we think about those perhaps are asymptomatic, so long as they are wearing the PPE, they could perhaps meet their loved ones protected in that way. So it's part of the armoury, but ultimately, as Chris said, it is up to the care homes whether they allow this or not. And we just to say that we are encouraging as much of this to take place as possible. So does that answer your question, Nigel?
Thank you, Richard. Yes, it does. Thanks.
That's great. I've also got, I do apologise, I may have got my order wrong, but Fiona and Jonathan have indicated to speak. So Fiona, can I ask you to comment or ask your question?
Thank you, Chairman. Firstly, I'm really grateful to the officers for actually giving us the opportunity at this panel to discuss the dementia strategy, and for all the questions that are great concern to all of us for coming out. So thank you so much for that. I think what I'm going to do is more of a plea than a question, but it follows on from comments from Dreda and William earlier. Totally agree with if anybody feels they have an underlying problem, they contact the GP, because dementia could be hidden, or other symptoms such as UTIs, depression, dehydration can all be hidden by dementia, or the other way around. So that would be an initial visit to a GP to find out if those particular symptoms are there, but thereafter becomes the difficulty, and for people who are already very stressed and anxious to then wade through the SIPS system, which can also be quite cumbersome. And I know we were talking about carers yesterday, a very productive discussion at full council on that. So the mental health assessments are probably some very lengthy, complicated forms which anyone would have difficulty completing, let alone somebody with a possible disability of any sort. At the moment, I know it's even more difficult with COVID because there's not so many face-to-face assessments. It's either the forms and then often a virtual discussion might be suggested. Again, that actually could probably cause even more anxiousness. And if anybody was actually capable of doing that and sitting there and going through these lengthy forms. So it's really a plea that maybe we could look at streamlining things a little bit, because this is myself and feedback I've received actually looking at the forms as a person without a disability or with dementia or any other illness, such illness as this, without having that added into the mix. So anything that could be done to simplify things, the better.
That is a very helpful plea, Fiona. James wishes to come in to comment.
Yeah, we do want to make the diagnostic process as smooth as possible for everyone, for the carer and for the service user. At the moment, in Hertfordshire, our mental health trust is prioritising the use of home visits as well as in-clinic appointments for memory assessments. They've always offered home visits. The number of people wanting to have their assessment done at home has risen, and it's around a quarter to a third of people now are having their memory assessment done at home. And HPFT, our trust in Hertfordshire, have not followed some other trusts in other regions of doing entirely virtual memory assessments through formats like this. But they are using a blended approach where a nurse will go out and visit the service user at home, and the consultant will join that through a technological system to provide that input in a kind of blended model, which makes the whole system kind of more efficient, but also enables a nurse to be with the patient. If you've got people that particularly have come forward and expressed concerns, do link them up to me, Fiona, and really welcome a chance to involve them. And we're working with voluntary sector partners and HPFT at the moment to just refresh that diagnostic pathway and what it looks like, and make sure that we're communicating it really simply and clearly to people, and what their options and choices are. So if there is opportunities to make it clearer for people, then it'd be really useful and really good to involve them in that process.
Thank you. Chairman, could I very quickly come back?
Yeah, please do, please do.
Clearly we have an additional problem here, in as much as obviously the northern part of the county is covered by the Cambridgeshire and Peterborough CCG. So we just need to make sure we're linking in, because it could be that the systems are slightly different. It shouldn't be, it should be streamlined, and actually the patients shouldn't see a difference. But just so that everybody is aware, I know it is known, but clearly this could make a difference to whichever authority and whichever clinical commissioning group carries out the assessments, because I know the two counties work very differently on this.
Okay. Yeah.
Thanks, Fiona. I think we'll just we'll hold that point. I'll ask officers to minute that, actually, about Cambridge and Peterborough CCG, because with ICS changes, we may have to revisit that, and I think it'd be helpful to do so. That's really helpful. I'm going to ask Jonathan, and I've got another comment to make. But Jonathan, if you could ask your question, and thank you for waiting.
No, that's fine. In a way, similar to what Dreda was talking about, but William was talking about something like self-diagnosis. My query, in a way, is the opposite to that, because I knew a couple where it seemed quite clear that the man in question had early stages dementia. The wife would not take him to the GP to check that out for some considerable time. Whether she wouldn't accept that he had dementia or couldn't take it in herself, I don't know. And even their son and daughter tried to persuade their mother to take their father in, but that didn't help until it got to the stage where things were really bad. And I suppose there's not an awful lot you can really do about that, because you're very much reliant on the carer, on the person who's giving support, in order to get that diagnosis in the first place. I mean, it's not like Childline, where you can ring up a number and say, look, something's happening at number 23 that I'm a bit concerned about. I suppose the only thing you can do is just publicise the fact that people should actually take their loved one into the GP very early on.
Thank you, John. I think that's the sentiment. Dreda, comment, then Simon and Chris. You're on mute. You're on mute, Dreda.
Sorry, absolutely. I think that was sort of the key issue I was trying to drive at in my former question, because the person with dementia is vulnerable, and they're very much in the hands of somebody who is kind of controlling the situation, if you like. And often it's because people, particularly a spouse, might be very concerned that if they whistleblow, if you like, on their partner's condition, that this person may be taken away and put in residential care or whatever. But there's genuine fears there. And so there's a lot of denial. But at the end of the day, you're not denying your own treatment, you're denying treatment and support for somebody else.
Yeah. Dreda, thank you. Simon?
Thank you. I think fear does play a big part in this, and the fear of what the diagnosis might mean, and all the changes that it means to people's lives. I mean, I think what we are doing is selling the benefits of a diagnosis, the fact that if you get an early diagnosis, you can plan, and your treatment is likely to be better, and you're less likely to end up in hospital in a crisis or in a care home in a crisis, because if you can put a planned package in place, people are less likely to go into crisis, and so are more likely to live well at home. But it's a publicity promotional encouragement sort of message. We can't force people to seek medical treatment if they don't wish to.
And I suppose at the heart of this is perhaps stigma. Stigma is reducing, and the more that the message perhaps goes out to all our communities that actually helping somebody to make the step towards diagnosis is really significant help that you can give somebody. But I can also imagine just how difficult that could be. And I guess that's part of the new strategy when we get round to one, will be how we best can do that, and what is the best vehicle. Chris, did you want to add something?
Yeah, just two final things on that. I mean, first of all, to mention, I think a really good point, Jonathan. One of the things that I know we support a number of the voluntary sector organisations in this area to work on is, for example, like peer mentoring. So when someone's gone through the same sort of situation that you've articulated, sometimes it's almost easier and more receptive for that message to be given by someone that's been through that journey as well, can give more reassurance and understanding. The final one was just to pick up, it's not totally related, but you mentioned that example of Childline, and if you've got a concern ringing, just to sort of make the panel aware and remind everyone that if there is ever a concern about about an adult and how they're being cared for, or you're worried about their welfare, on the website there is a reporting mechanism to go into our safeguarding team, because we have a statutory duty to look into that, and if people have got concerns around whether perhaps neglect or abuse is taking place. Not sure it was in that situation, Jonathan, but the reference to Childline is an important one, in that we do have similar mechanisms to spot adult abuse and safeguarding issues, and we do encourage members of the public to use that, and we can respond appropriately.
Yes, it's difficult because it's not intentional abuse, but it is abuse in another way. Yes.
Yeah, and often our professionals are trained in how to sort of uncover that, spot that, but doing that in a supportive way, so that it's best that we know about it, and if it's not founded, we don't do anything about it. So we'd rather know and have a chance to look into it.
Thanks.
That's really helpful. I suppose the only other point I was going to make, which is probably pertinent to this conversation, but for those living on their own and living with dementia, the assistive technology research that we've been doing is absolutely pertinent to mitigating some of those symptoms that James was talking about, which might make dementia worse or create mental instability and health issues, which the whole point of that program is to unpick and alert carers and family that something's not quite right. And so I think that is, I don't wish to reopen that debate around that. We can bring it, we will bring an iteration of that to panel next year. But that once diagnosis is confirmed, that is going to be such an important tool in addressing some of the issues we've talked about today. James and Simon and Helen, thank you for bringing the paper. Formally, we're going to note the postponement of the 5-year consultation and the implementation of this 1-year action plan, which we've looked at and we've debated this morning. I'm hugely grateful to you for coming to that conclusion, particularly during this pandemic period. I think it's the right decision to make. So if we could agree to the 1-year action plan and support the work that is being carried out, with the expectation that we will have a new dementia strategy starting next year at the end of this 1-year interim. Thank you. There we are. That's there's still one or two coming through, but that is agreed. So I'm grateful. That brings us to the end of our agenda this morning. And can I thank officers supporting the panel this morning, and thank panel for some thoughtful and empathetic debate across our agenda this morning. Really, really helpful, and we can all reflect on that, officers and members alike, as we move through what is at the moment looking like a rather brutal second peak that we're all dealing with, and throw Christmas into the mix. But as it is Christmas, can I wish everyone a happy Christmas and all the best for the new year. And I will see you all back in February. I will see you all before then. I'm sure we have other meetings before then, but if not, I will certainly see you then, and look forward to it. So that, as they say, is that. We will see each other in the new year. Thank you all very much.
Thanks, everybody.
Thank you.
Happy Christmas.
Happy New Year.
Bye bye now.
Cheers.